Welcome to the deep dive. Today we're tackling a situation where every second counts. Acute limb ischemia, or ALI. Think of it as a sudden red alert for a limb's blood supply.
Yeah, a real crisis situation.
And it demands immediate understanding.
Exactly. This isn't just about memorizing medical terms. It's about, recognizing a vascular emergency. Our goal in this deep dive is to equip you with a solid grasp of ALI.
Okay.
What triggers this sudden cutoff of blood flow, what the key indicators are, and crucially, the steps involved.
And hopefully some memory tips too.
Oh yes, definitely. We'll share some tips to help you nail down the essentials for quick recall.
Great. Okay, let's get right to it. When we say acute limb ischemia, what exactly is happening?
Well, at its core, ALI is a swift and severe drop in blood flow to a limb.
Okay.
Most often because an artery gets blocked somehow.
Right.
The critical concern here is rapid tissue damage.
Right.
And unfortunately, without swift action, it can lead to amputation. The main thing really is that every minute counts. Rapid action is the absolute priority.
So what are the usual suspects behind this sudden arterial blockage? What causes it?
The most frequent causes are a thrombus, that's a blood clot forming right there in the limb artery, or an embolus, which is the clot that has traveled from elsewhere in the body and then gets stuck in the limb.
Makes sense. Now, how does this relate to peripheral artery disease, or PAD? We hear about that quite a bit.
That's a really vital connection to make. Many individuals who experience ALI actually have underlying PAD.
Right.
Their arteries are already narrowed. So ALI can be a sudden, dangerous worsening in someone with this pre-existing condition.
Like a pipe that's already partially clogged, suddenly getting completely blocked.
Exactly that.
Yeah.
It really emphasizes the urgency. This isn't something to just watch. It needs immediate attention.
And how is ALI different from critical limb ischemia? That sounds kind of similar.
Yeah, the names are close, but it's different. Critical limb ischemia is more of a long-term chronic problem.
Okay.
It involves persistent pain in the leg even when resting. Often you see ulcers or even gangrene.
Right, so it's been going on a while.
Precisely. It signals a chronic issue of insufficient blood flow, whereas ALI is this abrupt, acute event. Sudden versus chronic, that's a key distinction for your recall.
Right, sudden versus chronic. Got it. So let's delve into the why. What are the main causes, the etiology of ALI?
Well, the common causes, as we've said, are thrombus formation within the limb arteries and emboli. Those are the big two.
Okay.
But we also need to consider trauma, physical injury to the limb, or a tear in the artery wall. That's arterial dissection. Inflammation of the blood vessels, vasculitis can do it too, and even external pressure squeezing an artery.
Okay, let's break down these emboli a bit more. Where do these traveling clots typically come from?
It's quite fascinating, actually, the variety of places. A very common source is atrial fibrillation AF, that irregular heartbeat where clots can form in the heart.
Right, I've heard of that link.
Yeah. We also see emboli after a recent heart attack from faulty heart valves or from aneurysms, those bulges in blood vessels. Even arteries narrowed by plaque atherosclerosis, the buildup of fatty deposits that can be a source if a piece breaks off.
So a bit of plaque can just float away.
It can, yeah. And less frequently, tumors or even foreign objects can lead to emboli. Basically, any condition that can cause blood clots in the heart or major vessels could potentially send an embolus down to a limb.
That's a surprisingly wide range of possibilities. What about the thrombi, the ones that form locally? What's usually behind those?
Often, these clots form at sites where arteries are already narrowed by atherosclerosis, that plaque buildup.
So again, linked to underlying artery disease.
Very often, yes.
Yeah.
It can be a rapid event if a piece of that plaque ruptures, triggering a sudden clot. Or it can be a more gradual process where a clot slowly builds up over time, eventually causing a complete blockage. You
also mentioned some other less common causes. What are some examples there?
Well, physical injury, trauma, as I said, that can certainly damage blood vessels. Raynaud's syndrome, which usually affects fingers and toes with severe blood vessel spasms, can very rarely cause acute limb ischemia. Then there's compartment syndrome.
Yes, you mentioned that. Dangerous pressure buildup.
Exactly. Dangerous buildup of pressure within a muscle compartment, often after a fracture or major soft tissue injury. That increased pressure can squeeze the blood vessels shut. Essentially, the perfusion pressure, the pressure of blood trying to get through, falls below the tissue pressure.
Okay.
We also see rare congenital issues, conditions present from birth, like aortic hypoplasia, where the aorta is underdeveloped, and for arm ischemia specifically, that's often linked to emboli from the heart, or damage to the subclavian artery supplying the arm, or something called thoracic outlet syndrome.
Where things get compressed near the collarbone.
That's the one. Nerves and blood vessels get squeezed in that space.
That gives us a really good handle on the why. Now, who is most at risk of developing acute limb ischemia? What are the risk factors?
The risk factors largely mirror those for general heart and blood vessel disease, really. Older individuals are more susceptible. And having pre-existing peripheral artery disease is a major underlying factor. Atrial fibrillation, as we discussed, significantly boosts the risk of emboli.
Okay.
Smoking is a huge contributor to vascular problems everywhere. Diabetes damages blood vessels, high blood pressure, high cholesterol. They also play a big role.
The usual suspects for cardiovascular disease, then.
Pretty much. Obesity, too, and a past history of blood clots or blockages in arteries. Think of it this way. Many things that harm your heart also threaten your limbs. Managing those underlying conditions is just crucial.
So what's actually happening physiologically when someone develops ALI, the pathophysiology?
So the core problem is that a reduced or completely blocked blood flow. Simple as that.
Okay.
This lack of blood flow leads to tissue. Hypoxia tissues aren't getting enough oxygen.
Right.
That, in turn, causes cellular damage. The body tries to respond by releasing inflammatory mediators, but unfortunately, this can sometimes make things worse.
Oh.
The crucial thing, the absolute critical factor, is the need to restore blood flow quickly, very quickly, to prevent irreversible tissue death, necrosis. Time is tissue. That's the mantra here.
Time is tissue. Got it. Now, if someone presents with sudden limb pain and, dysfunction, what else might be going on? What's on the differential diagnosis list?
Yeah, good question. It's important to consider other conditions that can mimic some symptoms. Deep vein thrombosis, DVT.
A clot in the vein, not the artery.
Exactly. That can cause pain and swelling. We've mentioned compartment syndrome already, but it's worth repeating because the pain and swelling can look similar.
Okay.
Nerve compression, like a pinched nerve, can cause pain, numbness, weakness, and of course, simple musculoskeletal injuries. Sprains, strains, fractures, they cause pain and limit movement.
So how do doctors tell the difference?
It comes down to a detailed medical history, a really thorough physical examination, and then imaging tests like angiography to actually see the blood vessels. So think DVT, compartment syndrome, nerve issues, and musculoskeletal problems as other possibilities.
How common is acute limb ischemia? Any idea of the epidemiology?
Looking at UK data, the incidence is roughly 10 new cases per 100,000 people each year.
Okay, so not super common, but not vanishingly rare either.
Exactly. And it's more commonly seen in older people and, as we've discussed, those who already have cardiovascular risk factors. So it tends to affect a particular group.
Okay, let's talk about what someone might actually experience. What are the key clinical features? What would you see, or what might the patient feel?
The classic symptoms are typically sudden and severe pain in the affected limb. Really bad pain.
Right.
You might also notice the skin looks pale, that's pallor, and the limb feels cool or cold to the touch. The pulses in the limb will likely be weak or even completely absent. People often experience muscle weakness, numbness, or tingling.
Pins and needles.
Yeah, pins and needles. And difficulty moving the limb, impaired motor function.
And what happens if it's not treated quickly? How does it progress?
Well, if it's left untreated, the limb tends to become progressively paler and colder. The pulses disappear completely. And eventually, you'll start seeing signs of tissue death, like blackening of the skin, gangrene.
Okay, that really highlights the urgency.
Absolutely.
You mentioned something earlier about the 6 Ps, and sounds like a good memory tool. Can you run through those again?
Yes. The classic 6 Ps of ALI are a really helpful mnemonic. So it's pain, usually at rest, pulselessness, no pulse felt, pallor, paleness, poikilothermia.
That's the cold one.
That's the one, perishingly cold. Basically, the limb can't regulate its temperature. Then paresthesia, pins and needles or numbness. And finally, paralysis, inability to move.
Paralysis is a late sign, you said.
Yes, that's a late and very serious sign. So remember, pain, pulselessness, pallor, perishingly cold, paresthesia, paralysis. The 6 PS, a critical checklist.
That's definitely helpful. Are there any nuances, though? Does it always present like that?
Good point. It's important to remember that in cases where the blockage is maybe a thrombus forming slowly in someone who already has PAD, not all 6 PS might be present initially. The onset might be a bit less dramatic.
Okay.
So when it's knowing someone, You need to consider how quickly the symptoms came on, any history of chronic arterial disease, potential sources for an embolus like known AF.
Right. Check the other limb, too.
Always compare the pulses in both limbs. Definitely. Also, look out for fixed modeling, that patchy skin discoloration that doesn't blanch when you press it. That often means irreversible damage.
Oh, dear.
And a word of caution.
No.
Sometimes the limb might look red when it's hanging down, but that can be misleading. Could be something else like gout or cellulitis. So while the 6Ps are classic, remember they might not all be there, especially with underlying PDE.
That's really helpful context. So how do doctors actually diagnose it for sure? What investigations are involved?
Imaging is absolutely key here. Doppler ultrasound is often the first step, uses sound waves to assess blood flow, kind of like a radar for arteries.
Okay.
Angiography, where they inject dye and take x-rays, is often seen as the gold standard for visualizing blockages properly. We also have CT angiography, which is a CP scan with contrast dye, specifically looking at blood vessels, and MRA, MR angiography, which uses MRI and avoids radiation.
So lots of ways to look at the arteries.
Yes. The main aim of all these is to pinpoint exactly where the blockage is and how bad it is. So remember, Doppler, angiography, CTA, MRA imaging is paramount.
What about blood tests? Do they play a role?
They do, yes. They provide important supporting information. A venous blood gas, VBG, can give an idea of tissue perfusion, how well oxygen is getting through.
Okay.
A full blood count, FBC, might show anemia or signs of infection. UNEs, urea, and electrolytes, check kidney function. That's important. Glucose to screen for diabetes. Creatine kinase, CK, can be high if there's muscle damage. Clotting studies, obviously, to check for clotting issues. And a blood group just in case surgery is needed urgently.
So they paint a picture of the patient's overall state.
Exactly. Crucial background information.
Are there any other useful tests?
Well, an EC is really useful to look for heart problems like AF, that potential source of emboli.
Makes sense.
We mentioned the arterial duplex scans and angiography. A simple handheld Doppler is also a great quick bedside tool just to check for pulses.
Right.
And if we're digging deeper into the cause, we might look at ESR, the sedimentation rate for inflammation, check a full lipid profile for cholesterol, maybe do a thrombophilia screen for clotting disorders.
Okay.
If the diagnosis is still unclear after initial checks, urgent arteriography is often needed. And finding the source of an embolus might involve an echo, an ultrasound of the heart, or ultrasounds of the aorta, or the leg arteries like the popliteal and femoral.
So quite a thorough workup. Once ALI is diagnosed, what's the plan? How is it managed? What are the urgent interventions?
The absolute #1 goal is immediate restoration of blood flow.
Huh.
I really can't stress the urgency enough.
Right. Time is tissue.
Precisely. The main interventions are thrombolysis, using drugs to dissolve the clot.
Plot busters.
Yep, embolectomy, surgically removing the clot. Or bypass grafting, creating a new route for blood flow around the blockage. Initial measures always include pain relief, oxygen, and starting heparin, a blood thinner, straight away.
Okay.
Management decisions are often guided by something called the Rutherford classification, which grades how severe the ALI is.
Oh, okay.
Revascularization, restoring that blood flow, can be done surgically or increasingly via less invasive endovascular methods using catheters. For emboli, surgical embolectomy is often the first choice.
Got it.
So the immediate steps are emergency hospital admission, consider open surgery or maybe angioplasty to widen the artery, start heparin, manage the pain, give oxygen.
Is there special equipment used?
Yes. For embolectomy, a specific tool called a Fogarty catheter is often used to pull the clot out. For clots that formed locally, thrombi, sometimes intra-arterial thrombolysis is used, delivering the clot busters right into the artery.
And longer term?
Longer-term care focuses on improving overall cardiovascular health, treating underlying conditions like AF, and using medications like anticoagulants or antiplatelets. But sadly, if the limb is just not viable, if the tissue damage is too extensive,
Then amputation is the only option.
unfortunately, yes. Sometimes amputation is necessary. The key management strategy, though, hinges on rapid revascularization drugs to dissolve, surgery to remove, or a bypass to go around.
What about the prognosis for someone with ALI? What's the outlook generally?
Well, it really depends on several key factors.
Yeah.
How severe the ischemia was, how long it lasted before treatment,
How quickly they got help.
exactly how quickly treatment was started, and any other underlying health problems the person has comorbidities.
Right.
Early intervention significantly boosts the chances of saving the limb. Delay or inadequate treatment sadly increases the risk of complications and limb loss.
That time is tissue message again.
It's critical. Complete blockage can lead to extensive irreversible tissue death within about 6 hours if surgical revascularization isn't done.
6 hours. Wow.
Yeah. And sadly, mortality rates remain quite high in ALI, often because the underlying clot, the thrombosis or embolism, can be a sign of other serious systemic health issues. Interestingly, a Cochrane review looked at surgery versus thrombolysis and found no significant difference in limb salvage or death rates at 1 year. Although thrombolysis might carry a slightly higher risk of certain complications like stroke.
Right.
And the surgical treatment itself isn't without risk. There's a significant 30-day mortality risk, maybe 15 to 25%, often due to related complications like heart problems or kidney issues.
So it's a serious event all round.
Very serious. Prevention-wise, long-term anticoagulation is important for people at high risk of thromboembolism. And managing all those cardiovascular risk factors, smoking, diabetes, blood pressure, cholesterol, that's absolutely crucial for both primary and secondary prevention. The critical insight for prognosis is just that direct link between speed of intervention and outcome. Delay is devastating.
What kind of complications can arise from ALI itself or maybe from the treatment?
Unfortunately, several complications are possible. Limb loss through amputation is, of course, the major one we want to avoid. Infection in the affected limb can occur. Some people might develop chronic limb ischemia afterwards, ongoing reduced blood flow.
Okay.
Delayed healing of wounds or surgical sites is a risk. New blood clots can form elsewhere. And there can be systemic problems affecting the whole body, things like kidney damage, cardiac events, often related to something called reperfusion injury.
Reperfusion injury. Can you explain what that is? That sounds counterintuitive. Injury from restoring blood flow.
It does sound odd, doesn't it? But what's fascinating, and a bit scary, is that restoring blood flow can sometimes cause more damage initially than the lack of flow itself.
How does that work?
Well, several things happen. Neutrophils, a type of white blood cell, can rush into the damaged area and cause inflammation, more tissue injury.
Okay.
The limb can swell up significantly, which might actually lead to compartment syndrome again, ironically.
Wow.
And when blood flow returns to damaged cells, they can leak their contents, nasty stuff, into the bloodstream. This can lead to acidosis, too much acid in the body, dangerously high potassium levels, hyperkalemia, which can cause serious heart rhythm problems, and the release of muscle protein, myoglobin, into the blood, myoglobinemia, which can really damage the kidneys, causing acute tubular necrosis.
Gosh.
And finally, the acute severe ischemia can sometimes permanently damage peripheral nerves, leading to long-term chronic pain syndromes. So paradoxically, yes, restoring blood flow can trigger this whole cascade. Doctors need to manage this reperfusion phase very carefully.
That's a really important point about reperfusion injury. It definitely highlights the complexities here. So to wrap things up, what are the absolute key things we should take away about acute limb ischemia for quick recall?
Okay, the crucial takeaways are ALI is sudden, it's serious, and it needs rapid diagnosis and immediate treatment. The goal is preventing devastating outcomes like limb loss. Remember the 6Ps: pain, pulselessness, pallor, poikilothermia, paresthesia, paralysis. They're a critical indicator. If you see those, think urgent action.
Right.
And above all, time is issue. Rapid revascularization is absolutely key to getting a better outcome.
Absolutely. And that message really hammers home that time is just so critical in managing this condition. Understanding the causes, the risks, and the need for immediate intervention can make a life-changing difference.
Definitely. And for those of you looking for more in-depth revision resources, maybe some practice questions on this and other important topics for your medical exams, be sure to head over to pastumsra.com.
And for even more free learning materials and helpful resources to support your preparation, don't forget to check out freemsra.com. Thanks for joining us for this deep dive into acute limb ischemia.